Okay, guys, sorry for the delay. We're going to go through your renal clearance quiz. So hopefully you get everything straight so you can really kill that final. Because remember, 50% of the exam is going to be on renal clearance and then dosing. Okay. So we're starting out with one of these tables, just like we did in the workshop when we learned about um, renal clearance. And we've got this case where we have an 18-year-old female who was in a motor vehicle accident. Has now acute renal failure, and she's 5'7", weighs 150 pounds. Her serum creatinine is 3.5. That means she's not clearing the creatinine normally, and that's because she has renal impairment. Her albumin is also decreased, and her AAG is increased due to the renal failure and trauma. She's on the drugs listed below here. Which of these drugs would you expect an increase in clearance if an osmotic diuretic were added? All right, so an osmotic diuretic, what is that going to do? Well, an osmotic diuretic is going to draw more water. So if this is the urine, this is the nephron, and this is the blood, an osmotic diuretic is going to draw more water into the urine and definitely block anything going back out into the blood, thereby making the drug that is in the nephron more and more dilute, isn't it? Because you're adding water. You're not letting that water. You're trying to get rid of water. So you're trying to keep more water in the urine. That's what a diuretic does, which dilutes whatever is in the nephron. So as that happens, what is that going to do? Well, that's going to affect reabsorption, isn't it? Our passive reabsorption is just like passive diffusion, and it is powered by a concentration gradient between the urine and the blood. So if you ruin that or lessen that concentration gradient, you're going to block some of that reabsorption, aren't you? And then what will happen is more of the drug is going to go out in the urine, in the bladder, thereby increasing the renal clearance, right? So if you give an osmotic diuretic, you're going to block any or not any, but some of the passive reabsorption, and therefore increase renal clearance. So the answer to this is any drug that's reabsorbed. And it doesn't matter if it's an acid or a base. Any drug that's predominantly reabsorbed is the answer to this. So now we have to figure out which of these are predominantly reabsorbed. So let's think about that. Now, how are we going to attack this? So what we want to do is compare what's coming into the glomerulus. So our glomerular filtration rate, or our glomerular filtration clearance, and we want to compare that to the end of the nephron, which is going out in the urine, which is your renal clearance. So we want to compare filtration clearance to renal clearance. So how do we calculate filtration clearance? Well, filtration clearance is your GFR times your fraction unbound. So we're going to take the fraction unbound that we're given here and multiply it times the GFR. So let's see. First of all, our clearance is in mils per minute. Okay, so we're good. So we're going to do this in mils per minute. GFR, normal GFR is 125 mils per minute. Now, that is in your on your calculations sheet, on your equation sheet. So you don't have to memorize that, but that's a normal GFR, which is just like your creatinine clearance. Normally is 125 mils per minute. So we'd multiply 0.9 times 125 to get the filtration clearance for ceftazidime. And so we're going to multiply by 0.95 for gentamicin, by 0.7 for phenytoin, and by, again, 0.9. So these two will have the same one, won't they? The same filtration clearance. So we can do that very quickly here. So gotta find my calculator. All right, so 125 times 0.9. Whoops, let me just clear out my 125 times 0.9 is 112.5 mils per minute. It's going to be the same thing for this one, right? Because they're both mils per minute. And then 0.95, so it's going to be a little bit more for gentamicin. This is 118.75 mils per minute. And then, whoopsie, let me just clean this up a little bit here. This is 118 mils, 0.75 mils per minute. And this is 112.5 mils per minute. So then we just have to do 0.7 times 125 to get 87.5 mils per minute. Okay, whoops, I don't want that. Okay, so, and then we have to figure out the renal clearance for each of these drugs. And that's just going to be the total clearance times the fraction excreted unchanged in the urine. So this would be 150 times 0.9, 90% of it's cleared by the kidneys. So this is 135. Can I move this? 135 mils per minute. And then this one's going to be 120 times 0.95. So this is 114 mils per minute. And then this is going to be 67 times, times 0. So this is going to be 0. That's easy. And then 150 times 0.9 again, which is, I think we've already done that, but we'll do it again. 135. Okay. So now we have to compare our glomerular filtration clearance to our renal clearance, making sure they're in the same units. They're both in mils per minute. So what's coming into the nephron as we come in is 112.5, and what's going out is 135. So drug must have been added, so this must be secreted. So this is a secreted base. And let's see, gentamicin is 18.75 coming in, but only 114 going out. So this is predominantly reabsorbed, isn't it? This has got drug going back into the blood. And 87.5 to 0 again is reabsorbed. And 135, I'm sorry, 112 to 135 drug is being added, so it's secreted. So secreted, reabsorbed, secreted, reabsorbed. So the answer to this is going to be anything that's reabsorbed. So it's going to be furosemide and gentamicin, isn't it? That's going to be your answer. So we did all the hard work, but we're going to move on to the next slide. So it's the same drugs, same situation, but which of these drugs would you expect a decrease in clearance? So we have a decrease in clearance if a drug that alkalinizes the urine. So alkalinization of the urine, remember, affects, again, drugs that are reabsorbed, right? So if we have a acid, it's going to have the ionized over the unionized species, and the base is the opposite, right? If we alkalinize the urine, we're going to favor the numerator of these species. So an acid is going to be more in the ionized form. Again, if we think of our nephron, if it's more in the ionized form, it's got more of a charge. It's not going to be reabsorbed, is it? We're going to block reabsorption again, and clearance is going to increase. So if we have an increase in clearance, we're actually looking for the opposite, aren't we? So it's not going to be an acid. Let's check out a base. A base is going to be more in the unionized form. Wait a minute. Yeah, it's going to be more in the unionized form. And therefore that favors reabsorption, doesn't it? So you're going to have an increase in reabsorption, and then it's not going to go out in the urine. So that's going to be a decrease in clearance. So this is a base that is reabsorbed. And let's see, we have to go back and see. We have a base that's reabsorbed is gentamicin. So the answer here is gentamicin. This is like a fun little detective story. All right, next problem, same drugs. We don't have to redo all the math. Which of these drugs would you expect a decrease in clearance if a weak base is added that is cleared by the kidneys, primarily secreted? Okay, we know the big concern about secreted drugs are other drugs that are going to compete for the same active secretion site. So remember, we've got our glomerulus, and then in the proximal tubule, we've got drug being added against a concentration gradient. So this is secretion. And what's necessary for the drug to move from the blood to the urine is a carrier system that's going to move the drug from the blood to the urine. And we know that acids compete with acids and bases compete with bases. So what's going to happen if we give another drug has with a KTS that's relatively low? What does KTS mean? Well, that's a concentration where you have half of these carrier systems full. So the lower the KTS, the higher the affinity, and they win the love triangle, don't they? So they win the ride into the urine. So this new drug that's added is going to win the ride into the urine over our first drug, but only if it's primarily secreted and that it's a base. Because remember, bases only compete with bases and acids only compete with acids. So we're looking for a base that is primarily secreted. So a base that's primarily secreted is ceftazidime. So the answer here is ceftazidime. Okay. All right, same issue. Which of these drugs would you be least likely to need to change the dosing regimen based upon her renal impairment? Okay, this one's an easy one. So this often happens, especially if you work in a hospital or a nursing home. You're going to pay attention to the patient's renal function. If their renal function starts to go down, you're going to think, do I need to make changes in their dosing regimen? And you're going to be looking for drugs that are highly dependent upon the kidney to be cleared. And so this is where we're going to look at FE, aren't we? So 90% of clearance is by the kidneys for ceftazidime, 95 for gentamicin, 0. There's our answer. Phenytoin is not dependent upon the kidneys to clear phenytoin. So this is going to be the one. Now, there's the caveat is, are the metabolites cleared by the kidney? We're not going to worry about that in this case, but you should be asking because usually metabolism makes a drug more water soluble. So the answer here is phenytoin because all of these are 90% dependent upon the kidneys for clearance. All right, a new drug is under development. It's just undergone phase 1 trials. Okay, total body clearance is 1,000 mils per minute. FE is 90%. Fraction unbound is 75%. It's not highly bound at all. Volume of distribution of 2.5 liters per kilogram, and it's a weak acid. Okay, so which of the following would affect drug clearance? Oh, did I not? I wonder if I didn't copy the rest of this question. Well, we'll just determine what it is. Okay, so first thing we have to do is figure out what's the predominant process. And remember, just like we did for that table, we're going to compare our glomerular filtration clearance to our renal clearance. So our glomerular filtration clearance is going to be 125. And since we're in mils per minute here, we can stay in mils per minute. So 125 mils per minute times the fraction unbound. So times 75.75. So 0.75, not 75, sorry. So 125 times 0.75 0.75 is 93.75 mils per minute. And our renal clearance is going to be 1,000 mils per minute. So I could do that in my head. That's 900 mils per minute. So 93 are coming into the nephron and 900 is going out. Well, that's big time secretion, right? So what we're worried about then are other weak acids that have, weak acids that have a lower KTS that are predominantly secreted. Does that make sense? That's what we're worried about. Those either being added or subtracted from the dose, from the drug profile. Drug K, Fe is 0, totally cleared by the liver. That's what Fe is 0 means, or we're assuming there's no renal clearance. Fraction amount is 0.14. Is cleared by the kidneys? No, false. False, false, false. Next, which of the following statements about tubular reabsorption? So tubular reabsorption is a passive process where the drug is moving from the urine into the blood. So passive process. So tubular reabsorption depends on the pH of the urine. Yes, because ionization character is one of the things that determines if it's going to be passively able to move. So yes, that's true. Highly ionized drug tend to remain in the urine and not be reabsorbed. That is true as well. Tubular reabsorption can only be achieved by an active transport process. Nope, that's secretion, isn't it? Tubular reabsorption is dependent upon a concentration gradient. Yes. So those are the three that are true. A normal creatinine clearance is 125 mils per minute. However, your patient's creatinine clearance is only 33 mils per minute. Well, that's easier. Renal function is just looking at that percentage from the normal and putting it in contrast to your patient's creatinine clearance. So normal is 125 mils per minute. And yours patient's is 33 mils per minute. So 33, it's going to be less than 0.33, right? 33 divided by 125 is a renal function of 0.264, or about, and I think I had you round it to your nearest hundredth. So it's going to go right there. So it's going to, the answer is 0.26. This means only about 20% of your nephrons are functioning normally. If the renal clearance is greater than filtration clearance, okay, what's coming in is the filtration clearance, and there's more going out than came into the nephron. So that means we've got secretion. It's primarily secreted. Name two processes in renal clearance of drugs that add drug to the nephron. All right, well, we know filtration does. And then as we move down, we've got secretion also adding. And then the third process is reabsorption. No, that takes it back, doesn't it? So these are your two right here. And that's it. Not bad, huh? Well, good luck in your studies. I hope this helped you to be ready for these questions I'm going to ask you about renal clearance on the final. Good luck. Thanks.